Okay, I think I'm one of the few clinicians in the room that has the chance that are either people getting very excited about my talk or they should be down. So we'll see what happens afterwards. I want to talk about the role of prebiotic fibers in chronic inflammatory disorders. And particularly I'll make you understand how already some people have talked about how the gut microbiome affects some of the inflammatory disorders, so I'll be brief on that. I'll talk a bit about the diets rather than only the fiber, and I'd like to see what the role of prebiotics and dietary therapies is for chronic inflammation. So I'm going to take you to the clinical realm. I'm particularly interested in the role of Crohn's disease and also colitis. And these are diseases that are chronic intestinal inflammations, where the difference is that in ulcerative colitis, this is confined to the colon. People have typical symptoms such as having bloody diarrhea. And versus Crohn's disease, is confined not only to the colon, but can be in the entire GI tract, mostly in the small bowel. So there's a difference in distribution, there's a difference in presentation, but the hallmark of this disease is a chronic intestinal inflammation that affects people in the prime of their life, a lot of them in very young people. Once you have this disease, that disease will come back. It will be almost like running a family practice. You see these people all the time. Once you have these people in your practice, you follow them along. So you asked the question, so what triggers the disease? I think if you come to this stage when you see, and this is a patient with ulcerative colitis, and here's a patient with Crohn's disease with one particular ulcer among a normal epithelium, there's actually also one of the differences, then it's really hard to ask questions about pathogenesis. It also turns out to be hard to implode therapies such as fibers and dietary therapy when the patient is really sick. So you have to be smarter on starting this earlier, and I come back to that later. So this is a map, this is a slide that I borrowed from Gil Kaplan in Calgary, who have been a landmark study on the prevalence of the disease. And this is like taken before 1960. You see that some of the areas, and typically Scandinavia here, Western Europe, in China. But what's really important is that if you look and go back further, and you look then into the area between 1980 and 2008, there's an incredible increase. I'm from the University of Alberta in Edmonton in Canada, and we're sitting on one of the highest amounts of this disease, both in Crohn's and colitis. And I feel like it's still only the top of the iceberg, and still more are coming through. And it's not only because we diagnose the disease better, it's a true increase of this disease. More importantly is that we see diseases that were never there in areas that were so-called low endemic areas. In Japan, particularly after the World War II, maybe because of the introduction of the diet. So there's a lot of things to consider, but it all indicates that there is an environmental factor responsible for this increase. So you really get the disease when you have a combination of genetic susceptibility, and we have over 160 susceptibility genes for those diseases. The environment, including the microbes, the diet, effect of smoking, and when you have the disease right in the middle, when you have the so-called two-hit theory that you have genetic susceptibility and an environmental factor, only then will you get sick. That also indicates that people that move from endemic areas, which like sub-Saharan Africa, and then migrate into Canada, will actually get the generation typically in the second generation of people. So I think enough has been said about the role of the intestinal microbe, how there's an incredible amount of interest in this. So looking at the intestinal microbe, how this can affect the disease, what are really the evidence? Well, the simplest way to say that is that I was studying this in the days, it was in North Carolina in Chapel Hill with Balfour Cider, is we had a rat model for that susceptibility gene was HLA-B27. When they were transgenic, the animals developed spontaneous colitis. Interesting, though, is we had a germ-free colony, and when you had these germ-free rats, they had no colitis, and also they did not have arthritis. This model was initially developed by rheumatologists who were interested in ankylosing spondylitis. As you know, this is where the genus is prevalent. When they introduced the cecal bacteria in these germ-free rats, they got aggressive colitis pretty rapidly. And if you introduce certain type of bacteria, Bacteroides vulgaris, anaerobe, you get moderate colitis. When with E. coli, you had no colitis at all. And later on, we showed the role of the probiotics, that if you give these animals lactobacillus before you give them the cecal bacteria, they were actually having protective effect. So this actually really what it says is established that not all microflora is like equal in inducing the disease. You have differences right there. And it indicates that microflora is important for getting the disease. The other factors are also proving this particular theory that I won't go into detail right now, but the role of antibiotics is there, the role of fecal deviation, making the disease better when you give the patient the stoma is another indication. So it all boils down to the fact that we have disease-inducing organisms, as seen on this part of the slide, and protective organisms on the other hand. Now this is a very simplified slide. I mean, some of these data are derived from the animal models, some of the data are sourced we have pathogenic E. coli in the Enterobacteriaceae group that are associated with Crohn's ileitis. On the other hand, you have the protective organisms, and of course there are the typical ones that are now being sold as probiotics, Bifidobacteria, lactobacilli. But later on, we have to realize that it is the most abundant organisms in our gut, the anaerobes, that are the short-chain fatty acid-producing bacteria that are becoming more and more important for protection. And one of them is the Faecolobacteria prausnitzii, as this organism is low in patients that once you do surgery and you take the disease bowel out in Crohn's patients, you get the disease back in that small bowel when they get anastomose, when they get them put together. And that disease recurrence after surgery seems to be associated with lower amounts of the Faecolobacteria prausnitzii. So gut bacteria keep you healthy, and I think I'll go over this quickly because most people already have gone over that, but it's a lot of good stuff, good, particularly metabolic functions, among them the short-chain fatty acids, and that will come out of gut bacteria. But there is also evidence for the following, that we have in lots of diseases, there is this so-called dysbiosis, and as I just alluded to. And if you look at this slide here, there is a whole host of organisms, not only in chronic intestinal inflammation and also colon cancer, where this is important, but other autoimmune diseases, including some multiple sclerosis, ankylosing spondylitis, where the gut bacteria are important. And of course, the diseases that are involved with the host metabolism, such as the obesity and type 2 diabetes, and heart disease and metabolic syndrome, where this is important as well. Now, this abnormality of the dysbiosis, in conjunction with what Karen was telling this morning, could also be due when you have a leaky gut, and it seems to be associated. And it's really important to tease what comes first and what comes second. So anyway, you have this inflammation. Now, what are you going to do about it? So first of all, the imbalances that so far they've been measured, and this is in the community of IBD patients, is there's first of all a decrease of diversity, and there's increase of certain bacteria, the proteobacteria, the E. coli, and it's a relative decrease of Clostridium rhuminococci and the decrease in Prausnitzii. So this is a busy slide, and what this slide really does is it tells you that the gut is a very complicated organ where you have bacteria on the other side, you have the immune system here, and as Karen told you this morning, that when you have leakages of the barrier, you connect the activation of the immune system, both the innate immune system as well as the adaptive immune system, eventually leading to tissue destruction. Now, most of the therapies that have been directed at inflammatory bowel disease have all been directed at the adaptive immune system, the increased amount of inflammation, anti-inflammatories, as well as the biologics that we have against, for instance, the production of TNF-alpha. Expensive therapies. What really has not been developed very well is the inciting organisms. What do the gut bacteria do? How can we change that? So there's a role for the so-called microflora-altering therapies, meaning stool transplantation, but also increasing in the use of probiotics, prebiotics, and of course specific antibiotics. So what we hope to do is to eventually, and this might be done when the disease is relatively quiet, is to bring the homeostasis back to baseline, like not in a dysbiotic state. So that we have a lot of, you can imagine that these kind of therapies, if you would talk about this 10, 15 years ago, people would basically say, well, you know what, we have these biologics that work great, what you're talking about. And nowadays with the development of the interest in microbiome, which follows parallel on the methods in order to detect them, there's been a fair amount of interest in what these bacteria can do in conjunction with the chronic intestinal inflammation. These are the foods that are naturally high in prebiotics, and you see a whole host of them, and particularly onions, garlic, chicory, and asparagus. So prebiotics is the definition, and that the definition is changing all the time. So this is a fairly old one. It's a non-digestible, fermentable. I think it has to include fermentation. So it will stimulate the growth of select, likely beneficial microorganisms in the gut. So that is eventually not only lead to the increase of those organisms, but more importantly the fermentation, and as the production of short-chain fatty acids, among the most abundant one, acetic acid, but also propionic acid, butyric acid, and some of the lactic acid as well. But as a side effect, the production of gases. So with that in mind, we, after doing some probiotic studies in Chapel Hill, I got this oligofructose-enriched inulin combination that I was looking at the rat model of colitis, and when I fed these rats the combination of oligofructose and inulin, you can appreciate and this was a feeding time of about just after after weaning we started them, after about 9 weeks I believe. We see quite a bit of reduction of inflammation. This is histology sections. This is cross-section to the colonic epithelium. You can see in a spontaneous colitis rat there's a fair amount of inflammation, both in the submucosa as well as in the epithelium itself. And if you give these animals this combination of prebiotics, there was a significant reduction. Not back to normal, but definitely reduced. At that moment, we were able to do some initial studies with looking at lactobacilli and bifido. So yeah, okay, we're all good. There's an increase of bifidobacteria and lactobacilli. More important, and then we did some studies and showed that not all the prebiotics are the same in their efficacy. You can see that phosphorus actually, looking at the gross gut score, this is a macroscopic inflammation marker, that you had less inflammation when you had phosphorus as inulin. Now that prebiotics are always believed you need gut bacteria and of course the effects. And I recently got across an interesting paper by Franzen and in showing that this is done in germ-free mice where they have absolutely no gut bacteria, and they were given the short and the long chain oligosaccharides. And you can actually see that there's changes here in the IgM production in the mesenteric lymph nodes, also depending on the chain length of it, as well as some of the macrophages. So you don't need always the bacteria in order to have the effect. There is definitely an effect in the absence of bacteria, but the bacteria will likely modulate these effects. So then after the rat studies, there were done studies in humans, and in ulcerative colitis is the first one by the Spanish group by Casellas in Barcelona, where they basically took patients with ulcerative colitis and they measured fecal calprotectin. Now fecal calprotectin is an objective stool marker of inflammation. So that actually tells you when that is elevated, there's definitely inflammation in the gut. So the patient can give a stool sample, you can measure that using an ELISA and then get an objective measurement of inflammation. And they were actually showing in a patient who had active ulcerative colitis, they were giving a standard therapy 3 grams of 5-ASA, so this is anti-inflammatory therapy, and what was randomized to getting the oligofructose enriched inulin, this is the same ones I used in the rat model, versus maltodextrin as control. And you can actually see that pretty quickly there's a difference between the fecal calprotectin at day 7 into this treatment and day 14, indicating that in patients with ulcerative colitis, this had promise. So then we did this study and should take patients with active ulcerative colitis, that people have inflammation in their gut, and we did initially a pilot study to see what was going on, and we had objective measurements of inflammation, not only their symptom score, but also how the intestine looked, where you can scope these people, you can see how it looks like before and after 9 weeks. And also we collected stool samples and colonic biopsies. Because we were interested in the microflora. We were interested in the production of short-chain fatty acids. So this is the study how it is allocated. We had one group in the low dose, this was 7.5 gram, and one in the high dose, the 15 gram. And then this is the completed intervention. So there's all small groups of people. Now, interesting here that we did find a dose effect. So in 15-gram dose, the people actually did, the responders, these are clinical endpoints, like amount of bowel movements, amount of blood in the stool, and you can see that the 15-gram dose did better than the 7.5. So we did have a dose effect. And that the adverse effects, unfortunately, were also seen in the highest dose. So you did have the gas and bloating. So something of a payoff that you have to be considering in this trial. Now, this is like if you give them prebiotics before and after. And there was an objective improvement on the people, particularly the one that was responding. That you go from you can see that it's inflamed, it looks very friable, to a less friable state, but not completely normal yet. This is after 9 weeks of treatment. So we did have a health benefit effect right here. Now, it's really important to look at the gut microbes that are associated with the epithelium. And so where we heard talks about the barrier function, we talked about the mucus layer and all those host of bacteria. All these bacteria that can play a role in several diseases, in several chronic diseases. So we found that when we looked at the microbiota in our patient group, the one that are between the mucosa-associated group and the non-mucosa, like the ones in the lumen, there was quite a bit of difference. So we kind of indicated, well, you know, these are different populations, and we have to look at different things. So this is some of the data that showing some of the bacteria that can change, but actually, interestingly, at some of the bacteria that are changing, this is from the 0 to the 9-week time point. There's only really a few bacteria that are changing with the highest dose mostly. So to say that these effects as taken together just by who is there becomes really a question. So then we got smart, I think we got smart, it's up to you to decide. But it may be more important to see what is the correlation between the responders and the gut bacteria changes and the ones that do not respond. As you see, there's about a 50% response rate in the highest dose. And so what you can see here, that the ones that are associated with response are in green, and the ones in red were associated with disease. And some of those green bacteria here, the Rosaburia, the Faecalibacterium, just like the Bacteriaceae, seem to be associated with response. So in other words, and what these bacteria all have in common is that they are butyrate producers. So in other words, molecularly the butyrate producing bacteria, if you have enough of those in your gut, that will predict response. And this was actually then showed in the butyrate production, you have the responders for the non-responders, and we also looked at some of the transporter enzymes involved in the butyrate transport and mRNA expression, all pointing in the same direction. So in other words, you need to have butyrate metabolism in order to get a response from these agents. So now we have set up a study where we actually looking at based on the dose of 15 grams a day. We do a placebo-controlled trial in patients that are in remission of their disease. They have no symptoms, and we're trying to prevent the disease. We're trying to prevent the disease at the follow-up of 6 months. We will take biopsies from the colon by sigmoidoscopy before and after, getting those mucosa-associated bacteria, and we'll have patients visits to make sure that they are compliant, that they stay on their own diet, because you really want to, in quote, control for the diet. So an interesting finding in our patients that metabolomics can actually have a predictive role for having future relapses. And metabolomics is the study of body fluids in urine and serum, and this is why we use both. In order to see people that are in clinical remission, 12 months later they have a clinical relapse. So this is why they're at baseline before they had any clinical relapses. And there was actually a clustering of patients that are relapsing versus people that are still in remission. And some of those metabolites were correlated with the host metabolism. And this is one of the first findings that metabolomics actually can be a biomarker here for predicting response. That same kind of metabolomics we would like to do in our current ongoing study with prebiotics to see what comes first. Do we see a bacterial microflora changes, what kind of metabolomic changes before relapses occur, and hopefully we hope to find a positive effect with our prebiotics. So I think this is one of the ways how you actually can set up these kind of studies, not only to say, okay, it works, yes or no, but what are the mechanisms, how is this related to microflora, how is it related to the function of bacteria in order to do this. So now to come to the role of diets. And so coming back to the rat model, we already had shown that in the rats that were getting rat chow, and this is a composition of the rat chow, we're getting beneficial responses from prebiotics. However, it's common that in the rat chow composition differs per season. Well, seasonal variations will likely lead to microbiome changes. So if you want to do a long-term experiment and you compare animals that are fed at different times of the season, you'll find differences in your baseline. So we thought, okay, let's standardize the diet to the AIN 76A diet, which is the common diet for growing rats. And you see already there are differences in this diet versus the rat chow. And most important difference is that although the fiber, whatever that means here, is the same, the saccharide composition of the AIN 76 is 50 versus 15 in the rat chow. So this is something to keep in mind. There's also a difference in fat, and there are no difference in protein. So when we compare the rats with this new diet and in presence of prebiotics, we saw actually something that you have to see that the rats that are fed the AIN 76 diet, this was a defined diet, all of a sudden when we fed them the different prebiotics, including immological, which is something we also tested, there was actually no effect anymore, no protective effect when we had them on this diet versus the other one. And it's shown in the cecum as well as in the colon. So we got a problem here. So it's maybe an interesting finding that diet might be overruling your supplementation. And you can also see if you do the linear discriminant analysis on the bacteria who was there, you can see that in the rat chow and the AIN 76 they're quite a bit different in the bacterial composition. Now, how the diet shapes the microflora, I think the classic study in the Proceeding of National Academy of Science was by Di Filippo in Burkina Faso versus the Western diet. You can see how the composition of the diets from the Western group versus the African group is quite different. So we know that diet will affect the microbiome. So we then asked the question, okay, what are is that the dietary changes seen in our society, and one of them, of course, is the fiber intake, but there are probably some other ones, like the increased amount of refined sugars, increased amount of animal fat and animal protein. So there is something, and that mostly retrospective studies, where they said there could be a correlation between dietary changes and maybe the increase of these diseases, ulcerative and Crohn's, increase of autoimmune diseases, and so on, and probably metabolic diet as well, and metabolic syndrome as well. So secondary, so we did actually develop then a dietary intervention study where we gave people an anti-inflammatory diet, and I'll come to it what that really means, versus a Canada Food Guide diet where people just eat out all the boxes and what the dietitian recommends. With a similar design as with the prebiotic design study I just showed you, with people with 6-month follow-up and collecting time points on the way on biomarkers on, serum and urine for metabolomics and microflora as well. Now to our, here you can see the results. So I tell you that the percentage of patients that flared in 6 months' time did not differ. But what we did see, there was a difference in the fecal calprotectin, the intestinal stool marker, at 3 months and at 6 months. So in other words, there was no difference between those groups, between the anti-inflammatory diet and the control diet, but after 3 months and 6 months we saw differences. At the same time, we saw the group that had the anti-inflammatory diet, there were difference in metabolomics versus the one and the other ones. So we know the metabolic differences as well. And we're currently analyzing these data in a large fashion on the different time points. Now, this disease is ankylosing spondylitis, and this is also one of the reasons that the rat model was developed if HLA-B27 plays a role. So also, this is a disease when it gets really bad, you get fusing of the vertebrae and leading to this kind of compositions. You don't want to get to this stage in order to treat the disease. We also know that in this disease, the gut microbiota is increasingly implicated and likely in the extraintestinal inflammatory disease, because this disease is associated with Crohn's and ulcerative colitis. And we also know that half of the patients that have ankylosing spondylitis also have gut inflammation. So there's reason to believe that the gut microflora plays a role in this. And how this will be given as going the same thing as what Karen was telling, that you get activation of the intestinal immune system, leading to a high amount of pro-inflammatory IL-23 and IL-17. And the drugs that currently are directed against these two cytokines. So also in ankylosing spondylitis, there's also this dysbiosis, albeit with different kind of organisms. But one thing in common, and they also have a lack of short-chain fatty acid producing bacteria. So it all seems to be pointing in the same direction, that fermentable carbohydrates could be very important in this. I cannot report on any studies that have been done, but I can also tell you that the interest by rheumatologists on the gut microbiome is expanding rapidly. So I think we'll see a movement in this direction. So what are the take-home points? I think that diets and dietary fibers, including prebiotics, affect the composition and the function of human microbiome. It also becomes clear that diets, as well as the prevalence of those chronic inflammatory disorders, such as IBD, have drastically changed. And I think it has a good promise for the gut microflora changing therapies using dietary fibers in these disorders, as I just shown, and hopefully with the kind of study design that I've done to look at longitudinal study design and look at mechanisms. Thank you.
Thank you very much, Professor Dieteman.